wanted to introduce myself and our district before I introduce our speakers for tonight's Opioid Epidemic presentation. I'm chair of the Marin Healthcare District Board, and our other members are Hank, if you could stand up, Simmons, and Larry Bedard, and then with our Building and Lease Committee, which sponsored this, let's say did the work, as well as Louis Weiner. For this presentation, we have Brian Sue, who's on staff here at Marin General, the orthopedist. And I want to thank Ramo and Matt and Jeff for presenting tonight. Ramo is the Medical Director of Pain Management at Marin General Hospital. Matt Willis is our County Public Health Officer. And Jeff DeVito is our Chief Addiction Director, physician with the Marin County. And he's also on staff here at Marin General. So I'm going to have Ramo, Matt, and Jeff take it away, and thank you so much.
Thank you.
Appreciate it. And also one other point, just for housekeeping, if it's helpful, it'd be great to have your questions taken at the end, and we have some index cards where you can write your questions on as well. Thanks.
Well, thank you everyone for being here tonight. Instead of the seated union, you're going to watch this, so thank you. Some optimistic news here as we talk about the opioid epidemic. We're going to talk about a crisis and an opportunity that's going on right now, here in America and here in Marin. For the first 20 minutes, I'm going to talk about what this opioid epidemic is and how we got here. And then Dr. Willis is going to talk about what's going on here in Marin County and what we've done to turn things around. And then to wrap things up, Dr. DeVito is going to talk about a little bit about addiction and how we manage it and some of the resources we have available here in Marin. So this is the problem. Over the last 20 years, there's been a steady increase in the number of deaths related to opioids. Our latest data comes for 2016. It takes several months to gather all of our data through CDC Wonder. And what the CDC has done is broken down the opioids into natural opioids like morphine and codeine, methadone, stanzolone. The synthetic opioids are like fentanyl or carfentanil, and then heroin in the orange. If you notice in the last 3 to 4 years especially, there's been a huge increase in the number of synthetic opioids like fentanyl and carfentanil, drugs you might get from a veterinarian or what anesthesiologists use. And what we're expecting to see are these numbers increase at this almost exponential pace for another few years before we start to see a declination. The big question is, when are we going to see that reduction, and how high will the death toll be before we get there? So opioid mortality is one piece of the puzzle, and the way many of these individuals die is through respiratory depression because of taking too much of the drug, trauma, suicide. Arrhythmias can happen with certain drugs, and then intravenous drug use leading to infectious complications. And we really have, in the media and even among physicians in the public health sectors, we've really looked at mortality. But the problem is much bigger than that. If you actually look at the morbidity, we have 5 times as many people addicted to heroin. We have 4 times that number of people who have a prescription opioid substance use disorder, and nearly 1 out of every 5 Americans is on a chronic opioid therapy regimen. So with that comes psychiatric and physiological morbidities as well. So we've talked about addiction, suicidal ideation, depression, anxiety, and financial stress with prescription opioids as well as with heroin, for example. And then all of the side effects physiologically that can occur, such as constipation and withdrawals. So you all probably saw the flyer in which we've highlighted some of these statistics. We constitute 4.6% of the world's population, consume 80% of the world's opioids. We consume nearly all of the hydrocodone in the world, and there are enough prescribed opioids for each American to take a prescription opioid every 4 hours for a month. Now you might think with all these opioids pouring into our country that we would be better as far as pain management. And if you look at any public health related outcome when it comes to pain management, not only are we not number 1, but we're far inferior than many other countries. So how did we get here? Well, it all started with this plant, who many of you can recognize it. It's the Papaverum somniferum. And what you see from this plant oozing out after it is excoriated is this goo or latex, which actually within it contains morphine and codeine. The entire history of humankind has used this plant in some way, shape, or form. Whether it's for sleep, for pain, for other reasons, it's been with us. And it wasn't until 1973 that we really understood how these drugs or that plant worked, in which we identified these receptors, mu, delta, kappa, and nociceptive. And the main reason why I bring up this slide is that everyone in this room has their own opioid system. So if you stub your toe on the coffee table while grabbing a glass of water, you have your own endogenous opioid system that's helping with pain management. But it goes beyond that, in that we have opioid receptors throughout our entire body, and they affect a lot of different systems. How you're breathing right now, how you defecate, how you urinate, how you think, how you sleep. All of those things are managed or controlled to some degree, small degree, by opioids. And I think of opioids like steroids, in that we certainly know that steroids can be helpful for specific situations, but they affect multiple organ systems. Just like opioids, they can be helpful for certain situations, but they affect multiple organ systems. So we need to be judicious in how we use them. In this slide, I have about a 50-year timeline. And I want to start out with the Controlled Substances Act of 1970 with Richard Nixon. And from that, we started delineating drugs by illicit, such as drugs like heroin, versus those that were medically useful but may have had some addiction potential, like oxycodone or morphine. And I think what that DEA schedule did was it provided a false sense of security in that some of these medical opioids were safer than heroin, when in fact all of these drugs are opioids. They all work at those receptors, and there is still the potential for addiction and all of the other consequences. Going through the 80s, we started seeing the development of other types of opioids, like extended release opioids like MS-Contin and OxyContin. As far as what happened as far as movements, the American Pain Society made pain the fifth vital sign, or the assessment of pain the fifth vital sign. The Joint Commission and the Veterans Affairs adopted that notion and incorporated it into the regulation. And then in 2007, Purdue Pharmaceuticals was sued, which I'll get into in just a bit. And it wasn't until 2016 that the Centers for Disease Control and Prevention created their guidelines about prescribing opioids for chronic non-cancer pain. So I want to remind everyone that if we take a dose of something and we have a response to it, it infers that we all have within us an endogenous system that is affected by that substance. And so we learn that drugs or substances have the potential for harm, the potential for good. And this was understood over 500 years ago, or nearly 500 years ago, by this gentleman, Paracelsus, who's speaking here in Latin. And if we translate that, what he says is, the dose makes the poison. So if I show you these 5 substances on the left, so many of you may be able to recognize them. We have the coca leaf in the upper left-hand corner. We have psychedelic mushrooms below. We have barley mash, which becomes alcohol. We have the papaver somniferum, and then I think everyone in this room can recognize marijuana. We can categorize these drugs as uppers, downers, hallucinogenics, cannabinoids, etc. But every one of these substances actually has a medical use. We actually use cocaine as a local anesthetic. We use derivatives of methamphetamine for attention and wakefulness. We use hallucinogenics for anesthesia, PTSD, depression. We use sedatives for anxiety, sedation, anesthesia. And of course we use the opioids, and of course we use cannabinoids for medical purposes. So the reason I bring this slide up is, even though we're talking about how awful and damaging the opioid epidemic is, whatever the next thing is, whether it's 10 or 20 years from now, if it's a cannabinoid or the next substance, we all have to remember there are pros and there are cons, and it's how we use these substances that makes all the differences. So what are the influences on the opioid epidemic? As I mentioned, I really think the beginning of the opioid epidemic began in 1996 with the introduction of a drug called OxyContin. Purdue Pharmaceuticals marketed it as abuse-resistant and less addictive. And it didn't take long as the explosion of this drug occurred, which was right in the beginning of the opioid epidemic, where a lawsuit was filed, and the payout from Purdue Pharmaceuticals was $600 million because they marketed the drugs falsely, and they knew it. Just like big tobacco knew a lot of things about nicotine's addictive potential. And we found out that 76%, nearly 4 out of 5 individuals who were heroin users, started with a prescription opioid. Now, in 2010, they created a new abuse-resistant formulation But what that did is it extended their patent another 13 years. So they continued to make a lot of money. And Raymond Sackler, who began Purdue Pharmaceuticals, was number 16th richest gentleman in Forbes magazine in 2015, making $3 billion from OxyContin that year and $35 billion from the drug over that 19-year period. And what's very interesting is that his older brother, Art, who was a psychiatrist, they both were psychiatrists, actually began the whole movement of marketing medicines. And this began with a drug called Valium, or diazepam, which is a benzodiazepine. And it was Art Sackler who developed the idea of selling a drug to physicians in the Journal of the American Medical Association. And one of his ads looked like this, where a woman's husband passed away, she became widowed, and you had 5 male physicians misogynistically looking at her in consternation, with her mother and sister also in despair. So how do you deal with that emotional distress? Well, give her a benzodiazepine. These kind of ads may not seem very odd to any of us in this room because we see it all the time now, but this was very novel in the 1960s. And what it did is it put Valium into the most prescribed drug for 14 years straight. It amassed $600 million in 1978 dollars, which is a lot of money. And Art Sackler went on to develop MS Contin, and then guess what? Told his brother, hey, I got an idea for this drug, oxycodone, where we can make a sustained release formulation, and here we are. In 1997, the Food and Drug Administration allowed expansion of direct-to-consumer marketing. So in the late 1990s, it was the first time you saw commercials for Viagra or for all these drugs that you see today. Before that, it was not possible. And the amount of money pharmaceutical companies paid for direct-to-consumer marketing was $2.5 billion, free samples, $8 billion, and direct-to-physician payments, $4 billion. Yes, physicians were paid to market these drugs, to tell people they were less addictive and abuse-resistant. And what happened was there's a lot of conflict of interest, of course. And in 2010, through the Affordable Care Act, we had the Physician Payment Sunshine Act, which promoted transparency in who's getting money for what. So any one of you can look any one of us up and find out where we're getting our money from. So a lot has changed since Norman Rockwell painted The Doctor and the Doll in 1929. The notion of the patient-physician relationship has changed quite a bit. In the United States, we're a bit fortunate in that we can do most of the things we want to do as long as the insurance company will cover it with our patients. But it should be remembered that we have to have a professional relationship with our patients. And so if we're prescribing a controlled substance, it's under the regulation of the Medical Board of California. And so if you are a friend or a family member and you want a friend who's a physician to write your prescription, that is not kosher, that is not legal. You have to have a professional patient-physician relationship in order to obtain a prescription, and the medical board is recognizing that and pursuing those complaints if they do occur. Now, in other healthcare systems, nationalized healthcare systems, you can't do necessarily what you want. So in many other countries in this world, you could not see an opioid epidemic because you would never be allowed to prescribe 400 milligrams of methadone or 500 milligrams of OxyContin twice a day. What we've also seen with the business side of healthcare is that the amount of time we're able to spend with patients has reduced. I think we all see that as physicians and as patients. And the average length of a visit is now down to 13 minutes. It's not enough time to go through all the risks with opioid therapies. Satisfaction surveys, or HCAP scores, there's been a lot of research looking at how, in order to help satisfaction surveys, we might be prescribing a lot more. And so we've certainly changed our satisfaction survey mechanisms, and we're going to see those changes this year. So there's been a lack of check mechanisms on the opioid epidemic, which I'm going to get into. And I really feel strongly that we have done a poor job in our education of physicians in this country, and that is why we're in the midst of this epidemic. So the number of hours devoted to pain education in our medical schools, median 9 hours. And in most other developed countries, it's at least double that. In most European countries, it's in the 20 to 30 hour range. Still not enough in my opinion, especially as a pain physician, but nonetheless, 9 hours is pretty miserable. And from that, we perpetuated a lot of myths, which many of you might have remembered from your medical school days if you were a physician, or from nursing school if you're a nurse. So we had this notion that there's no ceiling effect with opioids. What the ceiling effect is at a certain level, even if you give more of a drug, you're not going to get an increased effect. Certainly, you can only take so much Tylenol before you take more of it, you're not going to see more effect. But with opioids, you could take more and more and more, see more of an effect. And so we told people, hey, there's no ceiling, go to the moon with opioids. When in fact, there is a ceiling effect. You see these individuals with 1,000, 2,000 milligrams of morphine on, and they're saying, give me more, and nothing's happening. That's a ceiling. But it's just a very high ceiling. Secondly, we were taught that opioids are the most effective treatment for pain. Well, yes, there are certain situations where they are effective, acute, severe breakthrough pain, such as after surgery, cancer pain, and end-of-life care, certainly. But their use in chronic, non-cancer pain is controversial and generally not advised other than for specific situations. In fact, if you look at non-steroidal anti-inflammatory drugs like ibuprofen or naproxen, they are actually more effective in acute pain. But they have their own risks too. So we talk about the short-term effects of opioids. Often many of us remember this from medical school, the respiratory depression, the nausea, the vomiting. But many of us don't realize that there are long-term consequences in that individuals can develop low testosterone, menstrual cycles can become irregular, you'll gain weight, and then hyperalgesia is the notion that you can actually become more sensitive to pain. So in the mid-1990s, anesthesiologists recognized this whole concept by using a drug called remifentanil, which is an opioid that comes on really quickly and then it comes off within minutes. And what they noticed was patients were screaming in the recovery area. They wondered what was going on. So research started to look into this idea. And we have animal studies that have been repeated over and over, which have demonstrated that almost every opioid causes this phenomenon. And this is why I do not recommend opioids for chronic non-cancer pain, because we may actually be making patients worse as far as their pain management with the use of opioids. And to sort of prove that, we have a population health study from Denmark that looked at individuals with chronic pain and looked at those who did not use any opioids versus those who were on strong opioids. And what they found was the odds of recovery from chronic pain were 4 times higher among those not using any opioids compared to those using opioids. They also learned that the use of strong opioids was associated with poor health-related quality of life. And lastly, there was a higher risk of death for those who are on strong opioids. And we're certainly seeing that here in this country. So to conclude, we have evidence that opioids are not that effective in chronic non-cancer pain. There's been evidence that there is harm with long-term use. And there may be rare situations where opioids can be used for chronic pain management. But we have to go through the risks, the benefits, and do continuous monitoring. And some of the things you can see here, like patient-provider agreements, cures reporting, screening, naloxone, these gentlemen are going to get into. And next, Dr. Willis will go into what the epidemic looks like for Marin County and how we're turning things around. So thank you.
Thank you.
Thank you, Dr. Naidu. I'm going to. That was an amazing context of how we got to where we are now. We're going to shift gears to looking at kind of the Marin County experience. I want to start by thanking the healthcare district and the hospital for hosting this event. I'm convinced that this is the way we're going to get ahead of this epidemic ultimately, is through dialogue like this. This is a complex epidemic. It's not just an issue of healthcare. It's not just physicians needing to prescribe differently. It's going to be really something that our hospital administrators, our providers, our nurses, our school teachers, our law enforcement, public health, everyone has a role to play in addressing this epidemic. And part of our approach here in Marin County is to try and bring all those necessary stakeholders together to actually develop comprehensive strategies to address this epidemic over time. So as public health officer, I am a public servant. I work for the Department of Health and Human Services. Our mission is to promote and protect the health, well-being, self-sufficiency, and safety for all in Marin. And what has emerged as one of the most important threats to that safety and health is the epidemic of opioids. So it has become one of the priority issues for us as a health department. I'm going to go through some of the trends and some of the data that we've used to actually determine that this is a priority for us. one of the sort of gimmies came from the Robert Wood Johnson Foundation, County Health Rankings. Every year, University of Wisconsin and Robert Wood Johnson ranks every single county in the nation. There are 3,143 counties across the nation, 58 counties in the state of California, and ranks us according to about 30 different indicators of health. I'm not going to go through all of these, but Marin County ranks in the top half in almost all of those 30 indicators compared to other counties in California. And we were ranked the healthiest in 7 out of 8 years in the state of California, healthiest overall. What's important about this is that we consistently rank poorly in the same few indicators. And have a look at these. Excessive drinking, drug poisoning mortality rate, so this is accidental overdoses, alcohol impaired driving rates, so DUIs, and then they added another indicator, income inequality, so we have some of the largest disparities in income as a county. But 3 of those 4 are related to substance use. So obviously we're learning something about our county just from this, which is, from a public health standpoint, substance use is one of the most important issues for us as a county, and is important context for our relationship to the opioid epidemic. When I became health officer in 2013, having come from the CDC, as an epidemiologist and using data to answer questions, the first thing I wanted to know was, what is our situation with regards to opioids? I had been working at Marin Community Clinics for 1 year. Anecdotally, I had an experience where many of my patients were taking opioids at much higher doses than I was comfortable prescribing. I had inherited a practice from another physician. I had wonderful physical therapists who were working with me, and one of them is here tonight, trying to help with those patients. And many patients are actually getting both benzodiazepines and opioids. And so I had a sense, even before I became health officer, that this was something we needed to address. What we did was we were able to actually, that didn't come up. So what we saw was more than doubling of narcotic prescriptions in Marin County, so that we had 440,000 narcotic prescriptions in 2006, and we had over 100,000 narcotic prescriptions in 2013. So there was more than a doubling in the narcotic prescriptions in Marin over that period of time. We also had a corresponding doubling in the number of emergency department visits. We also saw a tripling in the number of accidental drug overdose deaths, 27 per year in 2012 and 2013. That's 1 accidental death every 2 weeks. And as you know, in a county like Marin, where everyone is 1 degree of separation from everyone else, each of those deaths had a profound effect across the community. So from these numbers, we knew that we needed to develop public health infrastructure to deal with this epidemic. At the same time, we were being increasingly aware of the lived experience of this epidemic among our families. This was an example of one of our Novato kids that went to UCSB, A student, took 2 Opana tablets one night at a party with his friends and never woke up. His father, Rick Torsham, came to me and said, I want to do what I can to help address this epidemic. And he helped form the coalition called RxSafe Marin. He was also bold enough to include in AJ's obituary that he died from a foolish mixture of alcohol and drugs. So not having a public health infrastructure, we have communicable disease, public health preparedness. Opioids, we did not have any funding or staff for opioids, and neither did our mental health team. Law enforcement was not stepping up to the plate, so there was a lack of civic leadership actually in trying to address this issue, and we thought that this was a public health issue. So one of the ways we decided to address this was actually having a town hall forum where we invited anyone who was interested in this issue to come and join us at the Sheraton in February of 2014. And we had about 100 people come, and at that point, I was sort of aware that we had hit a nerve, and that there was actually a lot of interest in joining this effort. And out of that meeting, which was really the kickoff of RxSafe Marin, we developed what's called a collective impact model to address this issue. And this is the architecture, if you will, of our coalition called RxSafe Marin. And I'd like to invite any of you who are interested to join this on any of our action teams. We have 5 action teams. One is organized around community-based prevention. Another is organized around the law enforcement aspects of this. We have a team dedicated to prescribers and pharmacists. We have a team that does intervention, treatment, and recovery. And then we have a data team, and we meet on a monthly basis. The backbone support is provided by my team at Health and Human Services. These are our core strategies that I'm just going to go over briefly. We're working on reducing the supply of opioids because we know there's a direct relationship between the amount of opioids being dispensed into a given community and the corresponding harms, whether it's opioid overdoses, emergency room visits, or addiction. So we're reducing supply through safe prescribing and safe disposal, reducing the demand for opioids by increasing community awareness of the harms of opioids and treatment for addiction, and then we're getting into reversing overdoses when they occur through making naloxone more widely available. So this is an action of the prescribers and pharmacists team. We had a goal to reduce opioids prescribed in Marin by 15% from 2014 to 2016 through developing and adopting safe prescribing guidelines. So in 2014, in the summertime, we gathered the medical directors of all the emergency departments together, our 3 EDs. And Jim Dietz was part of that effort. And basically just what do we see as this sort of standard of care for pain regarding opioids in an emergency department setting? And fortunately, we were able to come within just a couple of meetings with just some real consensus across all 3 EDs. And that was important because we needed to make sure that there wasn't idiosyncratic approaches in different healthcare settings. We wanted, our community, when they went into one of our emergency departments, to know they were going to get more or less the same treatment, whether it was Kaiser, Nevada Community Hospital, or Marin General Hospital. And that protected the hospitals as well. And so those are still, these are still active as the prescribing guidelines for emergency departments in Marin County. And then we expanded that to all outpatient clinics, particularly primary care clinics for the management of chronic pain with regards to opioids. Some of the elements that are most important among our prescribing guidelines are things like limiting the days, the number of days that you prescribe if you are prescribing opioids for acute pain. CDC just recently issued a study that sort of substantiates the reason why that's so important. Along the bottom here, you see the number of days supply in their first opioid prescription. So what this shows is that people who might have received a prescription for 10 days on their first opioid prescription, if you look at that blue line, about 20% of those people who were given 10 days on their first prescription are actually taking opioids still at 1 year. Because that 10 days led to more and another refill. And lo and behold, 1 in 5 of them at 1 year are still taking opioids, despite the fact that the intent of that first prescription was most likely a short duration. So we need to really be aware of the fact that when we're prescribing what we think are short acute management, we're actually setting the stage for long-term and potentially chronic use. Another important tool that we're promoting for safe prescribing is the CURE system. This is the database where we're able to see all controlled substance prescribing across the state. If you're considering prescribing an opioid to an individual, you can look into the CURE system and see who else might have prescribed to that person at any point in the last 6 months. And it's an important tool for determining whether people might be doctor shopping or whether there's dangerous combinations of drugs like opioids and benzodiazepines. An important reason why checking for benzodiazepines going straight to our death data, what we found is that when people die in Marin County with an opioid or related to an opioid, more often than not, there's another sedative on board at the same time. In fact, it's more common to overdose from a combination of opioids and benzodiazepines than it is to overdose from opioids alone in Marin County. And some of this is because some of our older patients are being prescribed combinations of benzos and opioids. So this has been one of the important messages that we've been offering to our clinics and clinicians. These are some of the results we found over the interval of 2014 to 2016. On the upper left, we had just the number of opioids prescribed per 10,000 residents. Significant decrease. This was the most important indicator for us was the MME, so the actual amount of total dosage of opioids being prescribed in Marin. We saw a 35% reduction over that 3-year interval. And we saw a 22% decrease in the number of people who were being prescribed both opioids and benzos. And then also a decrease on the lower left, a decrease in the number of people being prescribed very high doses. The other strategy around reducing the supply of opioids was to help people get rid of opioids that are in the community. So this 11 million, over 11 million opioid pills prescribed in Marin County in 2015. And the cure system, from our view, as from public health, we actually get to look at all prescriptions across the county. So I can actually count the number of pills prescribed in Marin County very specifically, whether they're benzos or opioids or Adderall or any other controlled substance. So that was enough for every man, woman, and child, had 44 pills. We also did a survey and found that half of Marin residents have leftover prescription medications in their homes, and that was often the source for especially young people accessing drugs that they didn't realize might be potentially very dangerous, like A.J. Torshawn accessing his father's Opana prescriptions. So we did an effort to try and actually expand the opportunities for people to dispose of unused and unwanted medications across the county. And this was one of our interesting first forays in dealing with pharmaceutical manufacturers directly, because they were obviously not interested in helping fund a network of take-back locations across the county and came up very strongly against it. We saw a strong public health argument for it. Fortunately, our supervisors agreed with us and voted unanimously to adopt an ordinance where we have now 25 locations across the county for a pharma-funded network of safe locations for take-back of unused and unwanted medications. And these are last year we had almost 8,000 pills, pounds of pills disposed of in Marin County through that network. The next strategy that I'm going to address is reducing the demand for opioids, and Dr. DeVito and I will be speaking on this together. Increasing community awareness. So our community-based prevention team has done a lot of work with the community directly. So we know that with all the work we're trying to do within our healthcare settings, we also need to have our community be aware of our patients need to be aware of the fact that there are new kinds of conversations happening. Expect a new conversation with your provider. It's not going to work if only physicians are being educated differently, because our society, as Dr. Knight has been enculturated to expect opioids as a solution for pain, and we need to rethink that across sectors. So we've been working hard to communicate directly to our community through a campaign, and some of these are just infographics that we've been using to advertise some of our efforts, like reducing the number of narcotics prescribed and helping people get rid of unused and unwanted medications. Myths versus facts, fact sheet, I won't go through all of those. This has been one of the more popular tools that we've produced through RxSafe Marin. This is, in any Kaiser exam room, you'll see this up. Marin Community Clinics, most of our FQHCs have these up. And what this, as you can see, what this does is it allows a clinician to say, the reason why I'm not prescribing, or I want to taper you off of your opioids, or the reason why I'm not going to prescribe opioids for you today, even though I know you're having back pain, is because all the things we're learning about the harms of these medicines. And I think in your case, the risks really do outweigh the potential benefits. And sort of overcoming that difficult and challenging conversation that often happens. Another infographic that we've developed. We're also using social media. We have a Facebook page. You can like us on Facebook. There's posting every couple days, RxSafe Marin. And then using some of the social media in our neighborhoods, like next door, just to sort of again get the conversation wider into the community. So those are some of the efforts that we've engaged in to both reduce the supply of opioids, reduce some of the demand for opioids in the community. Now Dr. DeVito, our Chief of Addiction Medicine, will talk about some of our efforts to reduce overdoses when they've occurred through Narcan, and talk about medication-assisted treatment.
Can you use all that? Thanks. Thanks. It's always humbling to follow after such great speakers that have been doing such great work. I want to add a caveat at the beginning because I think it's worth mentioning. When we're talking about opioids, we're talking about, decreasing prescriptions and whatnot. I think one thing to keep in mind is the difference between, between being dependent on opioids and being addicted to opioids. So it might seem like a subtle distinction, but it is worth bringing up. Someone in my field, again, I'm an addiction psychiatrist. When I'm working with someone who is, by definition, an addict or has a substance use disorder, is the other term that we use for it. This is someone that has not only a substance that they're using, but there's a whole constellation of behavioral things that go along with it. They've got cravings. It's impacting their life in different ways. They're spending an inordinate amount of time trying to obtain or recover from the effects of the substance that they're using. This is different than just dependence, physiologic dependence. So just because someone has tolerance to an opioid does not make them an addict per se. And in my line of work, we really work on the addict side of things from the standpoint of taking a look at all the behavioral parameters that go along with using a substance. I'm going to come back to that in a second when we're talking about medication-assisted treatment. But for starters, I wanted to talk a little bit about Narcan. So Narcan or naloxone has been around for a long time. This is not a new medication. It does one thing and does one thing only, and it does that one thing very well, which is that it goes into the body, it finds the mu-opioid receptors in the brain that may be occupied by other opioids, and it kicks them off. So it does that one thing and does that one thing only. So those of you that have worked in emergency room settings, or those of you who have rotated, you've probably seen someone been reversed potentially with Narcan. So if someone has taken opioids and is in an overdose situation, give them Narcan, it reverses the overdose. They may not be comfortable when that happens because they've now gone into, they now have no active opioids on their receptors, but they're alive and they're breathing. Okay, so why is this important? Why would we be thinking about, why would I be here talking about Narcan? Because underlying everything that I'm talking about here and that what Dr. Willis and Naidu have brought up is this idea that we've got people out there who are using opioids. And some of those people are going to overdose on those opioids. And what other parts of the country have done in order to address this, in order to decrease that mortality, is to have Narcan more widely available in the hands of people who are close to someone who's overdosed, so that they can potentially be reversed and they can survive. So 61 opioid overdoses were reversed with naloxone by emergency medical services in Marin County in 2016. So this is something, again, this is not new. The EMS has been using this, obviously, and those emergency room folks who are here will attest to using it. Now, this one I stole this one from Dr. Willis because I just love this slide. But this drives home a really important point, which is that over half of all drug overdose deaths in Marin County occur in the home. So that means that they're not overdosing in front of the emergency room necessarily. They're at home, which means that if you had Narcan at home with someone who's high risk of overdosing, you could potentially educate the family, you could educate people around them to use Narcan in real time to reverse the opioid overdose so that they don't go into respiratory depression and die. But this is just, again, data is good to have. It shows that in Marin County, this is what's happening. Okay, so what have we done, or what has been our strategy around getting naloxone or Narcan more widely available? We've been fortunate in the fact that as pharma is maligned in different areas. There is a pharma company that developed a proprietary intranasal version of Narcan. So this is, by intranasal, I mean you can put it, spray into somebody's nose, it's absorbed through the nasal mucosa, goes to the brain and can reverse an overdose. So you don't need to do an injection. And this has been incredibly helpful in other parts of the country because we've been able to get a nasal spray that can save somebody's life into the hands of people who may be around someone who's overdosing. So we just kind of canvassed the county and said, okay, who are in positions to see people early in an overdose? And let's figure out how to equip them with Narcan so that they can be ready to reverse an overdose if it should happen in front of them, or if they should arrive at a place where it's happened. Now, we've targeted to start with pharmacies. I'll come back to them in a second. First responders, in here I'm including police in this. I can say that with the exception of one small snafu that I didn't realize that Belvedere had its own police force, but every other police force in Marin County is now trained in carrying Narcan, and we've actually now had 4 overdose reversals via police in the community since we started, since I first did the training, which was May.
Don't overdose in Belvedere.
So right now, that's the bottom line, is don't overdose in Belvedere. Now, that being said, Belvedere is in line. We're going to do the training in the next couple of weeks, and they will be fully equipped, so not to worry. So the other places we're now doing, so inmates in the Marin County Jail are now being trained on Narcan. I can tell you from having done those trainings, that is the best audience. I mean, there's not a lot of other distractions, so you go in there, you get their full attention. But they know this. There were people that, when they did the training, raised their hand and said, "Oh, I've been reversed 3 times." So it just shows you that, like, you got to find custody to inmates who have identified themselves as having or being, you don't have to have an opioid use disorder, you just have to identify yourself as someone who wants to have the Narcan, and we'll give it to you when you're released from custody. We're working with schools to get it into, on 2 levels. On one level, kind of get it to the school nurses so that they're available to respond early in an overdose should it happen at school. Now, pharmacies is a big one because by law now in California, you can obtain naloxone, the intranasal naloxone, without a physician's prescription. So law allows someone to walk into a pharmacy, request Narcan, be given a short training by the pharmacist, and then receive Narcan. And almost all commercial insurers are covering it at full expense. I can't, since the complexities of commercial insurance are well beyond my brain capacity, I can't say that everyone is covering all naloxone, but I can say that Medicaid, or Medi-Cal, is covering 100% of all intranasal naloxone. So what we needed to do, though, is we needed to train pharmacists in how to do this and educate them that they could do this as well. And back in November, with the help of Dr. Willis and RxSafe Marin, we were able to put together a training program for pharmacists. That's my subtle segue. I'm pointing over into this corner to say that in this far corner here, there's additional information about RxSafe Marin. There's a sign-up sheet if people are interested in getting involved. There's also some handouts listing the current pharmacies that are providing naloxone without a physician's prescription. So if people are interested in picking that up, there's other assorted materials there as well. So medication-assisted treatment for opioid use disorder. So I mentioned before this idea that, when someone who has an identified problem with opioids could be a candidate for what we call medication-assisted treatment. Now, we have basically, I'm really distilling this down to some simple bullet points, but if people have questions or if people want to talk at more length with me at some point, my information is available. But we basically have 3 FDA-approved medications for the treatment of opioid use disorder. And when we say opioid use disorder, we mean someone who has, has an addiction to opioids. Now, the 3 options are buprenorphine or buprenorphine naloxone. This is a synthetic opioid. Then we also have methadone, which is also a synthetic opioid. And then we have naltrexone, which is an opioid blocker. So naltrexone itself is not an opioid, but it blocks the opioid receptor, so that if someone has naltrexone on board and they use an opioid on top of that, like if they shoot up heroin after they've had 50 milligrams of naltrexone, that opioid, that heroin, won't have anywhere to go. And they won't get high from it, they won't get a respiratory depression from it. I again kind of was mentioning here that we have 2 FDA-approved treatments for opioid use disorder that involve using another opioid. And then we have a non-opioid opioid blocking medication that's FDA approved. This is a graphic that I pulled off of the the internet where everybody pulls all their graphics off of by and large. But it's just driving home this point, which is that here you have, what's going on in the brain, for example, is that there are receptors that the opioids go to. And Dr. Naidu, I love that he, had this, that he put this in his talk, which is that the opioids that we take, whether it's heroin, methadone, OxyContin, or whatever, are taking advantage of receptors that are in the brain for a reason. They've been there because we have our own opioid system endogenously or in our brain that these medications, these drugs are actually taking advantage of that system. So buprenorphine, basically what it does is it goes to those same receptors that heroin would go to, and it occupies those receptors for up to about 24 hours. Same thing with methadone. Goes to those same opioid receptors in the brain, occupies it for about 24 to 30 hours, and then it drops off. That's why someone who's in methadone maintenance, if you're familiar at all with it, they get dosed once a day. They go to the clinic, they get a dose in the morning, they go back the next day, they get dosed in the morning. And the goal here with this is rooted in the fact that what we've noticed and what we know is that detox alone does not work. So just detoxing someone, when we look at the studies, those folks relapse, and they relapse hard and they relapse frequently. So when we see that, we know that the target is not just to get them off of the opioids, because relapse will happen, and when people relapse, a statistic that I just heard today is that the mortality rate in people who are relapsing on heroin, for example, is about 20% year on end. So about 1 in 5 people who are relapsing on heroin are going to, about 20% of them are going to die from an overdose. So this is what's happening when someone uses heroin. This is what's going on in the heroin addict's brain and body. They're using, and they're feeling relief from discomfort, or they're feeling some degree of euphoria. Then that drug, heroin lasts about 6 hours, it drops off. They go into withdrawal. So they use again, it goes back up. This is happening, this is a day in the life of a heroin addict. Every about 6 hours or so, this is what they're doing. So when we think about giving them something like buprenorphine or methadone, when we talk about giving them another opioid, what we're trying to do is this. We're trying to give them an opioid that will get on board and will maintain them for a day so they don't go through this cycle of up and down. Because it's this cycle of going into withdrawal that prompts a relapse. And then they use again, and then they may die. So this is our goal with, when I say agonist, partial agonist treatment. With that just basically means with buprenorphine or methadone. We give them once a day dose, target their dose in order to relieve their symptoms of withdrawal, and what we say is hold them for 24 hours until they can get their next dose. So I've distilled this, much to my chagrin, where I used to have like 16 slides that were talking about all of this. I've distilled this down to one slide to just kind of drive home some points, because there's a lot of misconceptions and there's a lot of stigma about people who are on maintenance treatment for opioids, whether it's methadone or buprenorphine. The fact of the matter is that medication-assisted treatment works. The vignette that I like to tell people is that, not to malign my own field of psychiatry, but when I was in training in psychiatry and I was prescribing antidepressants to people, and I'd see, some people got a little better, some people, it kind of stayed the same. When I got trained to do buprenorphine with patients, I was like, holy cow, people get better. I was like, I just wasn't seeing this in other parts of psychiatry. This blew my mind. So people really get better in this treatment. Now the studies, I've kind of distilled this down. The studies show, number one, people who are in medication-assisted treatment, they survive. In other words, they live. They have a better survival rate. These people also stay better engaged in treatment. And we do know that people generally do better the longer that they stay in a treatment. Methadone in particular actually shows a decrease in criminal activity. So in other words, people don't get arrested as much when they're on methadone. It also profound effects on co-infection rates with other either sexually transmitted diseases or diseases transmitted through IV drug use. Increases employment, improves birth outcomes. I mean, you can't show me an antidepressant study that could do this. You know, this is pretty incredible. Which to me, again, I get fired up about this because this is the piece that, you know, methadone is kind of relegated to like, oh, that's this thing that happens in these clinics far off, and you know, it's shrouded in mystery. But like, what's happening there is that these things are happening, which is pretty incredible when you think about it, relative to many of our other treatments. So I'll close this up with kind of talking a little bit about one of the common questions I get, which is, I have nowhere to refer people to. So where do you get this treatment? How do you get this treatment? So the font got very small on this one. That decreases the dramatic impact of getting to this slide, but nonetheless. So what are we doing at the county level and sort of system level? What we're doing is we're trying to take advantage of the fact that for once in the history of the treatment of addictions, this is something that the public is paying attention to, and as a result, the lawmakers are paying attention to, and we actually have some money to work with. One of the things, you know, our FQHCs are federally qualified health centers. These are, you know, Marin Community Clinics, Coastal Health Alliance, Marin City Health and Wellness, and Ritter Center have all received money from federal agency HRSA to expand their ability to treat opioid addiction as well as other substance use disorders. Medi-Cal has granted the county a waiver in order to expand the Medi-Cal, the Medicaid services that we're able to provide to people who have addiction. There used to be a lot of restrictions around what Medi-Cal would pay for in relation to addiction treatment. Many of those things have now been expanded, and we can now get reimbursement for things like residential care for Medicaid folks. The big one that I've been involved in is this quote-unquote hub and spoke grant, which is based out of the Marin Treatment Center. This basically is creating and trying to create a network in which people who have been identified or places where patients are going that may have opioid use disorders can be identified and then routed into medication-assisted treatment. And I say routed in, the idea here is that there are spokes, like a primary care office. They see somebody, they're like, listen, I don't know what to do with this client. They're on a lot of opioids. I wish that I could get some specialty consultation on this patient. And if they're qualified for services, you know, for medication-assisted treatment, I need some assistance in getting them in. We've now got Coastal Health Alliance, Marin Community Clinics. We're doing work with the emergency department here, as well as at Novato Community Hospital. Helen Vine, the county mental health services are all now sort of formally aligned with this model to route people in for medication-assisted treatment, as well as provide education to providers about how you can do this, you know, in your own practice. I always put this up here: talk to your doctor or insurance carrier. The piece that's always challenging is that a lot of the commercial insurers have their own panel of people, and you know, you've heard it all before in terms of it can sometimes be frustrating to call the insurance company and look for a list of providers that provide this service, only to find that those providers have died, which they did a study of this, and when they looked at these networks, like 10% of the providers on the list were dead. It's frustrating, but it still remains that for insurance providers that you may need to call your insurance provider if you have a commercial insurance, and you may need to pester them. You may need to call a number of different people in order to get to that. If you're a Medicaid recipient, you have access to kind of the county-based services, but there are also other available resources. I have the SAMHSA treatment locator. If you go onto SAMHSA, if you just Google SAMHSA treatment locator, you can plug in your zip code, and they'll give you a listing of all the providers who are able to prescribe buprenorphine, for example, within your geographic area. Kaiser does a lot of this work, so certainly if you're a Kaiser client, it's worth talking with your primary care provider, because they actually, as a managed care organization, have a lot of internal referral systems for this. Anyway. The other big thing that I've been doing is I've been training other physicians in how to do buprenorphine. You can do buprenorphine in an office-based setting. You just need to do a training with me, or it doesn't have to be with me, but I happen to be local. You can do a training with me in order to be eligible to prescribe buprenorphine in the treatment of opioid use disorder. The interesting thing that I always like to highlight when I talk about this is that, Dr. Naidu brought up this issue of in medical school, people get on average, 9 hours? That seems a lot to me relative to what my experience was in medical school. But people get very little training in opioids. In order to prescribe buprenorphine for the treatment of opioid use disorder, you have to go through an 8-hour training with me. Nobody had to go through an 8-hour training to prescribe OxyContin. Nobody still has to go through an 8-hour training to prescribe OxyContin, but you do have to go through an 8-hour training to prescribe this med, which again, never seems quite right to me, but suffice it to say that if you are seeing patients and you prescribe medications, talk to me if you're interested in getting waivered to learn how to do this treatment, because you can do this in your office. If you're not comfortable with doing it in your office, talk to me and I can help you get set up to do referrals over to Marin Treatment Center. That's kind of that's the big place that's doing this treatment right now. As usual, I've gone longer than I thought I would, but I'm sure there are questions that have been circulating. So, and again, this is the thank you slide. And again, there are lots of resources in the corner up here that people can take. First question I think I can answer is, so what are the county's plans to increase the number of pharmacies that have naloxone? I just want to make sure that, I don't know if this question came in before we talked about the pharmacies. So we have the list of the pharmacies that are currently able to provide this in the back corner over here. The plan to increase the number of pharmacies is, at this point, what we wanted to do is we wanted to kind of get a certain core set of pharmacies that were willing and able to do it so that we could then demystify it for other pharmacies. Some pharmacies have different restrictions and different regulations about how they get approval to do this. The Kaiser pharmacies, for example, have to go through a whole bunch of regional approvals, but we've been pursuing that with all the other, commercial chain and managed care pharmacies. Timelines for that, I couldn't tell you, because again, a lot of that is kind of gummed up in sort of internal policies that the pharmacies have to have in order to do this. But I personally was super excited that we got to the point through the help of the coalition that we at least had a few that were willing to do this. Our hope was that by at least getting a few out there, that others would kind of come online as well. But I don't know if Matt, you have more.
Is this microphone working? We'll just use this for the questions and answers. So pharmacies, just to be clear, so all pharmacies in Marin County will dispense naloxone with a prescription. So clinicians out there, if you're writing prescription for naloxone, your patients can go get those prescriptions filled at any pharmacy in the county. There's only 5 right now that actually will dispense it directly without a prescription. And so we're working and what they've told us is that there's actually sufficient demand, in their businesses. So if there's a business argument for having naloxone more widely available, they'll start furnishing it more. So I think the more we prescribe, we'll jumpstart the system for the pharmacies to be more, actually have it on the shelves rather than have to wait for it and prescribe it without a prescription.
How expensive is it if you were to walk into and your insurance company doesn't pay for it? Any idea?
It's the intranasal cash is about $150.
That's just a one shot.
It's 2.
2 shots.
Yeah, it comes in a box with 2 doses, and that's an important point. And that we're starting to see stronger and stronger with the synthetic opioids, like fentanyl, carfentanil, higher and higher. So the frequency. This is a trend that we're seeing in our emergency medical services data, which is that an increasing number of individuals, when they're reversed on Narcan, needed 2 doses, compared to the past, where 1 dose was sufficient because people were generally overdosing on non-synthetic opioids, which are generally lower in dose.
I'm an internist. One of my big challenges is people with chronic pain. They're on opiates for decades and trying to get them off. is probably not going to be practical to completely get them all. And many of them, insurance doesn't cover, things like physical therapy, psychotherapy is limited if you can find somebody. A partnership almost does not cover physical therapy. Medicare is, restricting the amount every year that you're allowed to get. And, a lot of this stuff is being driven by, what's available by insurance, what's covered, and the cost of the treatments. And I don't know that there are a whole lot of practices, pain practices in Marin that are accepting any partnership. And it's often difficult to find anyone who will take a Medicare patient.
Dr. Snyder, do you want to address, the healthy pain management, from our perspective as a public health issue, and the future of this epidemic is going to be partly tied to our ability to manage pain in different ways. And we are just at the beginning of understanding that more wholly, and certainly the payers is an important piece of this, but also just the culture and understanding of the nature of pain and what can be effective and what can we expect. I mean, there's something culturally about the United States that's different than other countries. Dr. Naidu mentioned, we have way more opioid sharing than any other nation. Do we have more pain than any other nation? Even within our nation, there's huge differences in the amount of opioids prescribed. I don't think you can make an argument that there's a lot more pain in Florida than there is in Minnesota. But in Florida, they have like 10 times more opioids being prescribed than they do in Minnesota. So what are the cultural differences about those two communities that lead to such disparities in the way opioids relate to pain? And other things we can learn about Minnesotans, that we might apply across. I know, right? We have a pain specialist here.
The global, to your point about do other countries actually have less pain, the Global Burden of Disease looked at this question and actually found the amount of chronic pain in other countries is very similar to ours. We don't have more chronic pain than percentage-wise than any other country. But what we've done with opioids has been far unique.
Can I make a pitch for? So, RxSafe Marin in April is hosting a community-wide convening. We have them every 3 a year, and they're generally attended by clinicians and just community members. And the theme of the next one in April is going to be healthy pain management. And Dr. Naidu is going to be participating on the panel for that conversation. But that's precisely the question. I think some of that's going to be advocacy in terms of trying to help our payers be more effective in supporting things, what are considered as alternatives for pain management.
Just to let you know, Marin Community Clinic offers classes for chronic pain for pain management with partnership. They take partnership. It's run by a PT and a nurse who does yoga in conjunction.
So,
But they won't let you have to see a Marin Community Clinic physician to get into those.
That's right.
And so your patient either has to drop their doctor that they've been with for many years and then go to Marin Community Clinic to access that, or they don't get the service.
So the observation was that there's an island of excellence that is maybe not available to all, but to some who, in partnership health plan and Marin community clinics, where they are actually advancing some non-narcotic alternatives for management of chronic pain, including pain management groups and yoga.
And to kind of piggyback to that point about, what do we do when payers aren't paying for a lot of the other services? It's tough. It's very tough. So I think about pain management with my 5 fingers. We have pain psychology, complementary integrative medicine, physical therapy, medications, and interventional pain or surgery. We do a lot of interventional pain surgery and medications in this country. Where the money needs to go, in my opinion, is pain psychology, is to complementary integrative and physical therapy. That's not where it's at right now. I think we saw some headway 3 years ago from the federal standpoint, putting money into mental health services. Not sure what's going to happen this year. But pain is both an emotional and sensory experience, and I think we lose that. We always think like pain is just trauma or surgery, but there's a huge emotional relay that we need to take into account. So I share your frustration. I don't have the answer, but we just have to continue to address it the best we can with the resources we have, and hopefully we can politically speak up to get more of the services we need. I want to, before I take hands, I have 3 cards in my hand, because that's what we wanted to do as far as how we triage questions. So So the first question is there any value in reducing preoperative use of opioids in chronic pain patients? It's a great question, and it's a bit of a double-edged answer. So of course we always want to reduce opioids in individuals, but the timing is very important. If we do it even within 3 months of someone having a surgery, you can actually set them up for a much harder perioperative course. And the reason for that is, number one, they still continue to have tolerance for some period of time. Number two, they'll have that opioid-induced hyperalgesia, which I mentioned. And number three, when they come into the hospital, they tell everyone, oh, I'm not taking any opioids. I'm fine. Turns out they were on 2,000 milligrams of morphine 3 months ago. They still have that tolerance, and then they're screaming 12 out of 10 pain for the next few days. So we also have this adage in anesthesiology, should you stop smoking before a surgery? I actually tell people not to stop, because if you do it within 2 weeks, they'll have a lot more airway secretions and complications. But if you stop 6 months in advance, great. So if you have enough time and you're planning a surgery maybe a year from now or greater than 6 months, definitely help people taper off. But you don't want to do it right before surgery. We've all been burned by that, and a lot of surgeons have tried to do that. Is there a role for perioperative cannabinoids for pain relief? Patients use them for postoperative pain. Yes, is the answer. The problem is marijuana is a Schedule I drug in this country that forbids us from doing research on the use of cannabinoids. So the countries that are leading the way in this research are Israel and Canada. So our neighbors up in the north have a lot of information about the use of perioperative cannabinoids. They have medicalized cannabinoids where you have a very specific dose and a very specific strain. Cannabinoids certainly play a role in analgesia, but I think they just play a role. They're not going to be the panacea that everyone hopes for them to be. So I think over time we will certainly see cannabinoids for pain perioperatively. Right now, in certain parts of the country, we do use cannabinoids perioperatively for nausea, in fact. So some of the cannabinoids we brought from the chemotherapy world as far as nausea and vomiting, we're starting to bring it to the perioperative world. And certainly we'll see more pain. Yeah, sure, man.
Regarding the cannabinoids, that's been an important topic for us as a public health department with the legalization. To understand the harms of cannabinoids and potential benefits, we did a review of the existing literature and found the National Academy of Sciences report from 2017, which had done a review of 10,000 studies from all over the nation, all over the world, because we can't do good studies here in the United States, as was mentioned. And they stratified the level of evidence around the strength and found substantial evidence for cannabinoids as being effective for addressing chronic pain. It was really one of the only true benefits they found for cannabinoids. The harms that they found were things like earlier onset for young people, for development of psychotic mental illness, people with long-term pulmonary issues actually got worse because if they're smoking it, low birth weight babies, and obviously alcohol, driving under the influence of cannabinoids increased risk. So there's clear evidence of some harms, but one of the benefits that they did find was related to the cannabinoid effectiveness in management of chronic pain. Did not mention perioperative pain.
All right, I'll get to this third card then, and then we can open it up to more hands or other cards. New insurance requirements are reducing the number of opioid pills we can use for chronic use. So what are the alternatives and what should we do to supplement? It's a great question. So I mentioned the CDC guidelines that came out in March 2016. They actually recommend that for acute pain, you shouldn't prescribe an opioid longer than 7 days. That includes after surgery. As many of you know, you probably get opioids for 30 days after surgery, depending on your surgeon. But the CDC has come down because we haven't had evidence that supports the use even beyond a week. So the big question has been, well, what do we use instead and what do we substitute? I'm going to probably be people's enemy by saying this, but I really think we just have to set expectations a little bit differently. Yes, there are other drugs we can use and other ways we can address pain, but I think the first thing we need to do is tell patients that the expected time for recovery is 3 to 7 days after surgery, for example, and that We've used opioids for short periods of time in many other countries, and patients have done well. And in fact, opioids can actually chronify or make your pain become worse over time. And I think that's a very important point that gets lost. So expectation management would be the first thing. As far as the alternatives, as I mentioned, the other modalities, complementary integrative, there are other neuropathic pain drugs. With everything else we mentioned, there are side effects. I mentioned that non-steroidal anti-inflammatory drugs are useful for acute pain, but they increase your cardiovascular adverse risk, gastritis, renal dysfunction. Gabapentinoids really came into the swing of things in perioperative care, but they can lead to cognitive dysfunction, sedation, tremors, psychotic features. So everything that's out there, even when we want to reach for something that seems like it's going to be really helpful, we just have to understand the risks. And every one of us responds to those drugs differently. So that's the challenge for us. And one of the things we're hoping to see in the future is personalized medicine, where I'm going to know Matt is a good candidate for gabapentin, but not a good candidate for opioids. And maybe Jeff is a good candidate for oxymorphone, but not a good candidate for anything else. Because we just don't know. Right now it's a trial and error. Try this, how you doing? Okay, great. Oh, that didn't work? Let's try something else. Which isn't a very elegant way to manage patients. So that's a long-winded answer to that question. And do you have some more cards?
Historically speaking, what are the go-to methods before?
I like to bring up Germany as a point. So you talk about the American epidemic to Germans, they laugh at you because what they have, their government developed a set of all indications for the use of opioids and have stated through their evidence, if you have headaches or migraines, you should not use opioids at all. There's no evidence for the use of opioids for migraines. If you have chronic low back pain, you should never use opioids. There's no evidence to support the use of opioids for chronic low back pain. Oh, do you have multiple sclerosis with severe pain through all of your extremities? You should use opioids, and up to a certain dose. So basically every physician knows exactly when to use opioids, how much, and for how long. And so when you go to international meetings and you show them these numbers, they're just like, what are you guys doing? Do you guys not read? Do you not understand there are some pain conditions that do warrant opioids and others that do not? And that's why I always go back to education. I think that still blows people away. 9 hours, maybe it sounds like a lot, but to me it's nothing. And certainly we could have societies, government, actually tell us how we should be using opioids. You know who's doing that for us now? Insurance companies. Mm-hmm. And they're trying to save the money. They're not necessarily trying to do what's best for patients. We really can do a better job. So I think everyone else has the same tools. I think expectations are very different when you practice in other countries. Like I did a research study in Brazil, and every woman who had a C-section, where the C-section rate was 80% of this hospital, they refused to have an opioid. They were all scared of becoming an addict. So they refused. Even if you offered morphine and they had 10 out of 10 pain from their Fan and Steel incisions, no, don't become an addict. So every culture is very different. Our culture is different. We demand a lot. We want to be pain-free and hike, 13 miles when we're 92, which is cool, which is fun. But nonetheless, we have really high expectations in our life. And sometimes we can't necessarily achieve them easily with the tools we have.
Can I just follow up on that, Ramon? On those other countries, do they have the vital signs of pain as a no? Okay, so that.
There was an interesting study of ICD-9, so discharge diagnoses from emergency departments across a large health system, which will go unnamed. And what they found is that for patients with the same discharge diagnosis of headache in an emergency department, and then they looked at prescribing patterns across all of their providers, and they found that some prescribers, some ED docs would prescribe opioids at 5% of the time with that diagnosis. And other ED docs would prescribe opiates 80% of the time with that same diagnosis. It's hard to imagine other conditions where there would be such a wide range of medical, allowable medical response by the physician. It's partly because what we're talking about is the lack of standardization. The other point there is that the other agency that will come in and help us standardize this is not just the insurance companies. To me, even more concerningly, it's legislators. So what's happening in some other, and because I work with the Health Officers Association of California, we work in the legislative space. There's a lot of crazy bills being introduced to try and get ahead of the opioid epidemic, because we're not able to manage it within our own ranks. And so legislators who are responding to they're elected, are putting legislation forward like you can only prescribe 3 days at a time, period, or no one under the age of 21 should ever get an opioid ever for any reason, kind of stuff, which sort of is not the best solution. But unless we get in front of it ourselves, we are opening ourselves up to simplistic and potentially successful legislative solutions.
There's a card here that was relevant to me and my experience here, but I'm interested in knowing about Medi-Cal-funded programs in the county for medication-assisted treatment. First question, do we have any? Sure, yes. How many? So currently, the easiest places for the Medi-Cal folks to get into medication-assisted treatment would be either at Marin City Health and Wellness, which is the FQHC, not surprisingly, in Marin City, and then also at Marin Treatment Center, which is a Medi-Cal provider. That being said, as I mentioned before, we're making connections with like MCC, for example, so hopefully in the near future, people who are in other venues will just be able to refer into MTC, but the end of the end of the line to that referral is MTC. That's Marin Treatment Center for folks that aren't aware. It's over on Lincoln Ave here in San Rafael. And the last question was, how long is the waiting list? This one, I really wanted to answer this one because this one's kind of good. There is no waiting list. They have capacity. They are open. They will see anybody. They have walk-in hours. You get there at 7 a.m. any day of the week, exception of Sunday, so I guess that's not every day. Monday through Friday, 7 a.m., you can walk in, get an intake appointment at Marin Treatment Center. So there is no waiting list there. I can't speak for what Marin City's waiting list is, but I can assure you it's probably not more than a few days.
Jim, can you clarify who can go to Marin Treatment Center, like what kinds of insurances?
Anybody can go to Marin Treatment Center. They are contracted with all the major. I say all. There are these ones that always surprise me. They're contracted with many of the major commercial insurers. They're contracted with the county and with Medi-Cal. They also have funding for the uninsured. So if they have no insurance whatsoever, they can still go there, and it's funded for that. They have a contract with Kaiser. They have a contract with Kaiser for the methadone program, but not for the buprenorphine. And the reason for that is because Kaiser has its own buprenorphine program. Yes?
How come I haven't heard anything about Narcotics Anonymous? Why, I mean, back in the 90s, that's all we had.
So that's a great question. I'm smiling because thank you. So the focus of this talk was to talk a lot about the medication-assisted treatment piece of it. When we talk about people who are recovering from addiction, that's one piece, as Dr. Naidu also brought up, as one piece of a bigger puzzle. And the 12-step programs, whether it's Narcotics Anonymous, whether it's Alcoholics Anonymous, still play a major role. There's a lot, again, I get on my soapboxes, there's a lot of misinformation about Narcotics Anonymous and its effectiveness and other 12-step programs. If people are interested in talking to me about that, I'm happy to wax at length about that. Suffice it to say that for some people, Narcotics Anonymous and Alcoholics Anonymous and 12-step programs are highly effective. We've found that combining medication-assisted treatment with 12-step programming can also be highly effective. The one part that sometimes is a problem for some people is that they may be on medication-assisted treatment, buprenorphine or methadone, and there may be certain Narcotics Anonymous 12-step groups that are not accepting of people being on maintenance treatment. My recommendation to people in that setting is try a different group. Not all groups are the same. They're obviously not centralized. People who know 12-step know that there's the big book, but beyond that, there's no sort of mandates from on high that say each group has to look a different way. But each group will take on its own flavor, and there are some that are not welcoming of people who are on maintenance treatment. I tell people there's a gazillion groups. This is not sort of one-stop shopping. But thank you for bringing that up. it remains a large piece of treatment and an important one.
From the public health standpoint, would you support the development of a medically supervised safe injection site in Marin?
It's an easy question.
Maybe I'll explain what it is.
So he asked, would we support a safe injection site here in Marin County? There's a lot of evidence that safe injection sites are an evidence-based harm reduction model to address this issue. They've been successfully implemented in Canada and Vancouver. If the outcomes you're looking at are drug overdose deaths, infections from dirty needle use, and managing the addiction. The answer, unfortunately, the political context for that is so intense that it's something that is sort of a non-feasible right now at this point in time from a political standpoint. But we have supported, the health officers have supported legislation that would allow safe injection sites in San Francisco and others to sort of pilot and test what that model might look like. That legislation has not been successful yet so far in the state of California, but will remain behind it.
A question about rehab centers, but one of the consequences of the opioid addiction is an explosion of unregulated rehab centers. There was a piece in the New York Times 2 or 3 weeks ago, and there's no continuity in terms of how these rehab centers are operating, how they're treating their patients. Patients are dying. Can you address that? Is there a leader in our community that's going to talk about rehab centers and what they should look like and how they should function? Or
Another real softball, easy question. No, I'm aware of aware of this sadly on sort of multiple fronts. There's this explosion of places that would be happy to take $75,000 of your money to go there for 3 weeks for non-evidence-based treatments. Is there an official guidance about this? No. Is there anything in the works about official guidance about this? That's interesting. I'm not aware of one, either at the state level or at the local level, but it's certainly something that you've piqued my interest about in terms of providing guidance. Because bringing that up, obviously you've dealt with this. You've had to.
I've read about it, and I feel like it's the elephant in the room because there's no legislation that's really addressing it. They're scrambling, as you said, to do something about the opioid epidemic. And now we have all these people running around making buckets of money on rehab centers, and they're not really helping us.
There's also nothing in the literature that allows us, unfortunately, to currently be able to kind of pre-screen people to say, like, listen, this person is going to do better with a 12-step abstinence-based model versus this person is going to do better with buprenorphine versus this person is going to do better with methadone. So some of that comes down to sort of clinical judgment. We also don't know from an evidence-based standpoint who's going to do better with a program that's in the church basement, once a week versus who may do better in a $75,000 a month program in Malibu. Not to pick on Malibu, but that's where they all seem to be, although they're in Marin too. But so I don't have any official guidance on that. Suffice it to say, though, that I do think that it's important to think about what are the evidence-based treatments for addictions right now. Evidence-based treatments are for opioid use disorder, buprenorphine, methadone, naltrexone. Psychotherapies, cognitive behavioral therapy, dialectical behavioral therapy, skills-based treatments. Treatments that directly address how you're going to deal with urges, cravings, difficult situations, and how you're going to respond to them. I would add that another evidence-based treatment, even though there's controversy about this, is 12-step, and that there is good evidence to suggest that 12-step is effective.
I think the other benefit we have in this county with regards to that is because of the regard that we're, through the coalition and other obviously interested agencies like Marin General Hospital, there is vigilance across the system around this. So those opportunists who are taking advantage of this epidemic there's not a lot of room under the radar in Marin County around this. And I think we're probably in a better place to identify outliers who are trying to take advantage of this situation.
Last question. So one of the things we talked about is differences in prescriber behaviors, provider behavior prescribing opioids and things. Is there anything we're doing to change that, to change prescribing behavior or change that behavior?
Yeah, I mean, one of the explicit goals of the RxSafe Marin effort is influencing, prescribers and supporting the way that they can prescribe more safely. Some of them are technical tools like the cure system that I mentioned, looking actually each and every time to see what someone's prescribing history may have been. The other is tools to help navigate the conversation with the patients. We recognize that the reason people sometimes are still prescribing unsafely is that patients are coming to them with pain. We are inculturated as physicians to respond to that in compassionate ways by offering them something that they can walk away with that reckons as therapeutic. We need to expand our armamentarium of things that reckon that way. Right now we still have this idea, reach behind yourself on the shelf, there's a pill that will help, and it's very easy and it's also very quick. Dr. Naidu mentioned we have 13 minutes on average per visit. It takes longer to have that conversation with someone that you're trying to set limits than it does to just write that prescription, and the patient walks away often satisfied and might give you a nice little review on Yelp. So there's a lot to this. And I should add that contrary to what you might intuitively believe, we're actually not seeing the patients who are having those conversations and limits are being set. Those patients don't, by and large, actually complain about the care that they're receiving. There was a strong concern that patients would be unsatisfied and reckon as unsatisfactory in terms of their reviews of their physicians or the systems in which they work. We're not seeing that, and it's partly because of the relationship that signifies in those conversations. So there's a lot of tools that we're trying to empower our physicians with in terms of safe prescribing, and those are some of them.
Thank you.
And I think we look at it from a top-down and bottom-up approach. I think Matt talks about the top-down approach. You have some data understanding how certain prescribers are prescribing, right? Mm-hmm. So it's a secret. So he can actually identify who those providers are, and maybe we can direct efforts towards them. From the bottom,
academic detail.
yeah. And from the bottom up, it's people like me trying to go around and teach people and teach medical students and residents. So there's the bottom up, top down. There are carrots and there are sticks. So we try to incentivize individuals to understand what those, what the benefits are of reducing opioids. But you can't really tell someone you definitely saved a life today. It's hard to quantify that, say you've done that. And then there are regulatory agencies who are coming after physicians and saying, you're going to jail because you overprescribed. And we have those stories, and we, market those stories and scare other physicians. So that's kind of the way it's been. Hopefully we see more of an organic bottom-up approach with incentivization rather than punishment to get where we want to go, but that's hard. All right, well, thank you, everyone.
Nice to see you.
My wife said,
Okay.